Okay, so good morning, everyone. Welcome to Black Independence Day. Thank you for joining us. I'm really excited to moderate this specific panel called The Curious Case of COVID-19, where we will discuss how inequities such as poverty and healthcare access are impacting the Black community, especially in the midst of the COVID-19 pandemic. And it will also discuss what can be done to create better outcomes and reduce risk in communities of color. My name is Fanta. I am currently the program manager for the Compass Investor Program at RFK Human Rights, which is the business and investor engagement pillar of the foundation. We engage with investors who control upwards of $6 trillion in assets under management, and we engage with them on the issues of human rights to consider while investing. These issues include labor and supply chain, technology and data, diversity, inclusion, and racial and economic justice. My background is in public health and financial services, but it is also combined with my passion for mental health and human rights. Before we start, I just wanted to highlight some housekeeping items. The session will be recorded and will be made available after the conference. Feel free to use the chat box to add comments. You can have side discussions or to show us some love. That's always great. But also, if you're having any technical issues, please feel free to add that to the chat so that we can be sure to address that. If you have any questions, if you can specifically add those questions to the Q&A box just so we can see that. And I'll try my best to weave in those questions into the discussion, but of course we have 10 to 15 minutes at the end to answer all of your questions. And if you're having any actual technical issues, please contact the conference organizers. So before I introduce the panelists, I wanted to provide some background info just for context setting. So health disparities between Blacks and whites have run deep in the US. And we know that the history of this nation, without a doubt, has caused these disparities and what further contributes to the negative health outcomes we see in the Black community today. There are certain social factors, which we call the social determinants of health in the public health sector, that have important implications for health risk and the ability to attain health insurance coverage, leading to uneven access to services and poor health outcomes. These social determinants of health include racism, poverty, income inequality, wealth inequality, food insecurity, and the lack of safe, affordable housing. And hopefully you can stay for some of the other sessions today that will cover some of these topics. When we look specifically at the data, we see that Black women are 3 to 4 times more likely to die from pregnancy-related causes than white women, that the Black infant mortality rate is twice the rate of white infants, that Blacks are more likely to die from cancer and heart disease than whites and are at a greater risk of onset of diabetes, and that the prostate cancer mortality rate is 2.5 times higher in Black men than for non-Hispanic white men, just to name a few. And then when we look at residential segregation, we see that mainly Black and Hispanic areas are more likely to lack hospitals and other healthcare providers, such as primary health providers and mental health providers. So these systemic healthcare challenges have become more of an issue with the rise of the COVID-19 pandemic. Since the start of the pandemic in the US, we have a total of 5 million COVID cases and about 166,000 deaths. Yesterday, we saw 53,000 new cases and 1,000 new deaths. Nationwide, Black people account for 23% of the COVID deaths, which is 2.5 times the rate of white people. So because Black people account for 14% of the US population, that is a significant percentage of death per capita. All in all, racial health disparities in this country have cost so many people of color, particularly Black people, their health and their lives. I'm excited to be joined here today by 2 amazing panelists who will help me dissect some of these health disparities, especially in the midst of COVID-19. I'm joined by James Bell III, DSW-C, who is the State Assistant Administrator for the Michigan Department of Health and Human Services, and Adrianna Boulin, MPH, who is the Community Engagement Manager for the Fenway Institute at Fenway Health. So let's talk about COVID. Everyone in this room has been impacted by COVID in some shape or form. The impacts of the pandemic have far exceeded that of any modern day pandemic, which makes it the worst public health crisis seen globally in a century. The healthcare sector suffered some of the worst impacts from COVID-19, such as product shortages, such as PPEs, ventilators, to massive increases in critically ill patients at hospitals, which overwhelmed the healthcare infrastructure, which demonstrated the weaknesses and holes that we have in our healthcare system. So I'll start with you, James. Can you briefly touch on some of the impacts of the COVID-19 pandemic and the impacts that it's had on the healthcare system?
Absolutely, and good morning, everyone. Thank you so much for allowing me to come today. When we think about the healthcare sector as a whole, we can talk about how COVID-19 has transformed the entire patient care experience. You think about how you've seen this uptick in telemedicine and telehealth as an alternative to people actually being inside of a doctor's office. But to me, when you start thinking about some of the challenges with that, there's gaps, right? You have to look into who has access to internet, to Wi-Fi. when you think about the digital divide. So I'm from Michigan. You can look at a city like Detroit, where half of the Black families in Detroit don't have access to wireless, right? And that's not just a cost thing, that's actually the technology is not always available. You can also look into the research that says that studies have found that ambulatory care practices have declined significantly, but we understand that these kind of emergencies still happen. So what's happening? Who's not getting care when they need it? And the other thing that we don't think about or talk about as often is the cost associated with healthcare. The cost for treating a COVID-19 patient is about $20,000 more than the average. And then if you're looking at an individual who's actually on a ventilator, that's more like $88,000. And if we're talking about the disparities that you described, like people without insurance, who's going to cover that bill? About the fact that we already live in an era where uncompensated care is an issue and bad debt is an issue. What we'll see in the future as a result of COVID-19 will be unprecedented.
Very true. So, Adrianna, let's look specifically at the Black community and the COVID-19 pandemic. Can you explain to the audience how communities of color, particularly the Black community, are disproportionately impacted by COVID? And then from that, what are some of the factors, inequities that contribute to the increased risk of getting sick and dying from COVID-19?
Yeah, thank you for that. And hello, everyone. Thank you for having me here. I'm so excited to be here with you, James, as well as you, Fanta, moderating. So when I think about COVID, I think of it in two ways. One, the actual disease, and then two, what's going on during this time. And I want to loop in the fact that attention has come up to the pandemic that has been happening for 400 years, which I'm sure we'll get to, but there's a lot happening during this time. So first, about the actual disease, the disease itself, people who have pre-existing conditions or are who are at risk for a number of reasons, which I'm sure we'll explore in a moment, and some you've already mentioned, folks who are essential workers, folks who are living in areas where they can't necessarily participate in COVID prevention and being further away from folks and 6 feet away, that's not as accessible. And it happens to have Black Americans or Black people in general are more impacted because they have other comorbidities and diseases that put them at greater risks. And the reasons for them being at greater risk for those diseases is other structural pieces in our system. So there's so many things that are interwoven. And so why Black folks are disproportionately impacted during COVID is why Black folks are always disproportionately impacted by anything that poses any kind of risk to us. It's though we don't have the capacity to maintain that. So that is why that happens from a COVID perspective. And just structurally, it's really hard for someone to navigate. James mentioned just what folks have access to: childcare, a time when school is not in session, a time when schools are deciding whether they're going to be in session or not, or haven't made the decision, and parents have to make it, or parent has to make a decision about what they're going to do for work, and having to work through those nuances. And depending on your socioeconomic status, not having the availability for a private daycare or teacher, et cetera, there just are things that aren't as accessible, and our system doesn't flow in which right now where, and I'm sure we'll talk about how we can make that happen, but our system doesn't flow right now that can accommodate different life experiences. The American dream is only possible within the standard of those that, have that perspective and lived experience.
Well, you mentioned childcare and school. So I want to touch on the younger population. So when we first heard of COVID, it was something that we were told only older people can get impacted by it. Younger people, pretty much you're good. You don't really have to worry about getting COVID, or at least dying from COVID, because you'll be able to recover if you get it. But now we're seeing that's not true. We're seeing younger people are dying from COVID. Younger people are catching COVID. But then we're also seeing how children who are in schools are also being impacted by COVID, because we see in Georgia how they're told to return back to school. They're going to school, and they were seeing an increase and uptick of cases within children that are attending these schools. So my question to you, Adrianna, is what are some of the impacts that COVID will have on children specifically, and not only their physical health, but also in terms of like education, but also their like mental health as well?
Yeah, my mind first goes to their mental health and development. You know, depending on the age of a child, these are really critical years where they're understanding themselves, their surroundings, their environment. And it can both be a time of opportunity while also being a time of great confusion, because, you know, the way the world has worked, in which we have built our foundation and become aware, is completely different. So it's almost an opportunity now where a young person can see a world where everything that we knew to be is now becoming something different, and it could be inspiring for that child to explore. But, you know, in the most immediate, this is a time where the structures that we as people, especially children, have all been used to, and it can be very confusing and stressful. And so this is a time now where really understanding yourself and grounding yourself, which as adults we may have the capacity to do, but as a child you don't necessarily have the capacity to do. And as a child who is a parent who might be having a hard time navigating and processing that, it can be really hard. And, you know, in a home where it's more than one child and one parent, or both parents, there are just so many different life experiences that can challenge that. And just by virtue of being a kid and loving to go out, this is not an environment where you can just go out and explore. There's just so much more keeping a child inside and on a screen. And, you know, so there's a lot of different things for a child to navigate right now that can impact them.
Absolutely. And then James, from your end, you know, and then having the background in social work, can you kind of touch on, like, what are some of the immediate, you know, impacts that we'll see COVID have on these children? And especially smaller children who, to Adrianna's point, you know, they're still processing this, they're still developing. There's just so much that's just going on as just being a 5-year-old, you know, but then not being able to go outside, not really understanding what's happening. So from like a social worker's perspective, you know, what are just some of the immediate impacts that you're seeing or that you think COVID will have on these children?
Sure. So I have 2 4-year-olds upstairs at the moment, so it's relatively close to me. When I think about the immediate impacts, I can often draw parallels to other pandemics that we've seen. So you could think about Hurricane Katrina's, the Hurricane Sandy's, you think about school shootings. Mm. Children often develop mental health needs. You know, you're developing anxiety, depression, there's disruptive behavior in school, there's sleep disorders. There's a ton of different impacts that, as a result of this change in this critical, like this sentinel period of their lives, they may actually end up stuck there. Like the way that they process information may be impacted by this current moment. And I think it's a challenge for parents, as you know, you want to maintain their safety, but you also want to make a decision of when it comes to their education and growth. I think at this current juncture, we'll see that COVID-19 is actually going to shape the worldview of these children the same way that the Great Depression impacted the children of that generation.
No, that's great. And I think being able to draw parallels from like other pandemics, I think definitely helps with that. So just taking a step back again, and then, you know, talking more about inequities largely. I know we kind of touched on this before, but, you know, going back to Adrianna, your point about this racial pandemic that has been going on for 400 years, which obviously impacts, you know, like our healthcare system today. So can you touch on, you know, some of, you know, those issues that still exist within our healthcare system, such as, let's say, discrimination within the healthcare system and physician bias, et cetera? Can you kind of touch on those inequities? And then with that, you know, why is recognizing physician bias so critical, especially during this pandemic?
Yeah. So some of the inequities that exist, I think one is in our approach. We have these downstream issues that we're seeing, that you see in the healthcare facility and when folks are coming in, and we're not thinking about their upstream cause and what infrastructure needs to be in place to prevent that downstream issue. And so oftentimes when folks are looking at how to support people of color, how to support Black people, they're looking at the resulting issue. So for example, this person is not engaged in care, and they have they are suffering diabetes. They're not here to get their medicine. They keep they keep not showing up for appointments, instead of thinking, why do they keep not showing up to appointments? It's because they have to work, and because we don't have hours during times that they're available. Are we offering them any other options? And, you know, we talk about that, you know, as a form of case management, but that needs to be embedded in our process, because we have a world of people with different life experiences, different perspectives, different family dynamics and life dynamics. And because we don't navigate through the healthcare system in that way naturally, a lot of people get lost along the way. And then something else that I want to bring into that connects is the trans theoretical model, stages of change. You have different areas of pre-contemplation, contemplation, you know, really maintaining that idea. There's all along that wheel. And I love it being presented in a wheel, because you can enter and exit anywhere on that model at any time. And you have to understand where someone is so that you can understand how they can best receive what you're trying to support them to do themselves. And I think the one challenge here that contributes to inequities is healthcare system doesn't approach people in general in that way, or they only approach a certain experience of people in that kind of way. And because we don't have enough people in the healthcare system that look like us, that share our experience and understand that dynamic, it's not embedded in our system.
Yeah, and we've definitely seen that studies have shown that, especially in the Black community, that healthcare and like the service is just, you know, significantly better when it's given by someone who looks like them, you know? And, you know, we, with reason, have a lot of trust issues with the healthcare system.
Valid.
So, you know, walking into a space where, you know, someone maybe from, let's say, a really rural area in the Deep South, and then you, like, the only health facility that you have access to, there's like physicians that don't look like you. So already you're walking into that, like, I don't want to tell the physician this because there's already preconceived notions about, you know, certain use of alcohol and drugs, and et cetera, within my community. So if I mention something, it's going to be, oh, of course, you know. Or when it comes to pain, like, we know when it comes to pain tolerance, a lot of us are not given like the pain treatment that we need, because there's this belief that you can handle pain, you're good. And we see that whether women are given birth, or we see that, you know, when it comes to other pain issues that we see in our community. So with that, I just want to kind of talk more about your respective roles, and then some of the inequities that you're seeing in your spaces, because obviously these inequities exist within the whole healthcare system, but I think it'll be helpful for the audience to get a better idea of, you know, what it is that you two do within the healthcare space, and then some of the inequities that you're seeing. So James, can you start that conversation?
Sure. And I just want to put this into the space because we haven't said it blatantly yet. One, that race is not a risk factor, especially when we're talking about COVID-19. It's race.
Mm-hmm.
And part of the reason why our pain tolerance is not treated the same is often because of racism as well. When you look back through history, you start looking at slavery, we were identified as something completely different. We were built to be stronger, to handle pain more,
Mm-hmm.
and perpetuated through our medical industry. So I just wanted to put that into the space.
Yeah, thank you.
When it comes to my work, so I work for the Michigan Department of Health and Human Services, which, being fully transparent, has a history of that mistrust. That same thing that we're talking about when it comes to patients, it exists with community when it comes to government. So I'm actually responsible for our state's lead strategy. And thinking about the era that we're in right now, we're not that far removed from when the Flint water crisis initially occurred. And so when you're talking about inequities in my work, my scope is typically laser focused on when it comes to child lead exposure. We're seeing some of the same parallels in child lead exposure that you would see in COVID-19. And the reasons why are identical. You talk about structural racism. You talk about why certain communities are built in certain places, why there's also certain lead landfills, because they're in certain places due to zoning laws. Why are those zoning laws exist? Because of institutional racism that said that Black families won't have access to a financial market. And so understanding that, my focus is on how do we remove the barriers that prevent families from having access to safe, affordable, and adequate housing, while also making sure that children are safe in a location. Because I realize there's not going to be this economic uptick overnight. But I also have to make sure that families are not exposing their children to lead because they can't afford to get out of their home.
Adrianna, can you touch on that within your role?
So in my role, I help support or direct rather community engagement and outreach in clinical research, and specifically HIV prevention and treatment research. And so there's a number of different trials that are done at the research division, which I'm in at Fenway Health. Something that we've just started doing is preparing for the COVID-19 vaccine studies, which we're also leading. And a big part of my role has been a couple of things, especially in community engagement, understanding where the community's perspectives is on vaccines, naming that there is medical trust, acknowledging that it's valid and that it comes from somewhere, and also acknowledging that we have daily instances from our administration and our daily experiences throughout our world that reinforce those historical things that have happened in the past. It's always mentioned, you know, there are historical things that happened in the past, but there are things that happen in the now, today, that reinforce what we reflect on. You know, Tuskegee is always brought up and Henrietta Lacks, but there's today examples that reinforce that. So it's one, naming and acknowledging that, and then also identifying how we as a research institution can support and amplify the work that's already being done in the community. Because what has happened in research is on a volunteer basis. You know, there's no one going into communities and forcing a population to be a part of a research study. But what my role and what we do as a research institution is to inform the community that for something to be developed with our bodies in mind, we have to be a part of that, and are a part of it in terms of researchers and vaccine developers and different individuals that are all a part of this. We also need the folks who are a part of the study to represent who we're trying to help. And because communities of color, especially Black people, are greatly disproportionately impacted, you know, 81 in every 100,000 people are Black people, whereas only 33 of that 100,000 people are white people. Black and Latinx people are 4 times more likely to be hospitalized for COVID-19, and you think about why those things are. And just to take a step back, I realized we didn't touch on physician bias, and I wanted to talk about it, just talk about bias in general. In the research world, we really try and be conscious of our own bias, and really have a system where we are literally not only meeting someone where they are and meeting everyone we interact with where they are, but making the space for that to happen. Because it's really easy as a physician or as a researcher to see someone as a number, as someone as a part of the population you're studying. We are so intersectional. And so my role is really understanding that, identifying the disproportionate impacts, and figuring out ways that we can improve that. And so some of the work that I'm doing at Fenway Health is working with the Boston Black COVID Coalition, and identifying some of the initiatives that they have that we can support, and also encouraging them to inform us of what we can do in the community to help support and educate COVID-19 prevention. So that's a lot of the work that I do, but really just understanding where the community is at, what their needs are, and how we can hold space and amplify their voices.
Absolutely. And then speaking of amplifying voices, I definitely want to save space and allow maybe like 5 minutes for us to really touch on the Black Lives Matter movement. And with that, I just want to thank the organizers for putting this together, but for also starting this in the midst of, you know, the racial tensions that we saw over the past 3 months. Yes, it has been happening for 400 years, but we're seeing it take, much different forms today. But one thing that we notice is within the Black Lives Matter movement, it predominantly is about police brutality, which of course is extremely important. But I think that oftentimes people forget that when we're on the street saying Black Lives Matter, we're not saying that Black Lives Matter only when we're getting killed by police. We're saying Black Lives Matter within every single context.
Correct.
Education, housing, finances, healthcare. We're fighting for our right to live within every single part of that word. Like we want to live, to see tomorrow. We want our mothers to live, to give birth and to be able to see tomorrow, and to have her son or her daughter also see tomorrow. So when we say Black Lives Matter, we're saying it within every single context. So my question for you is like, how can we hold space for, discussions about, healthcare within the Black Lives Matter movement? So essentially, how can we elevate these health inequities in our call to action for justice within the Black Lives Matter movement?
Yeah, I think, and James, feel free to chime in as well, but I think we need to have a culture of supporting each other, and not to suggest that we haven't, but I think we need to even more so. We need to share resources. I think a lot of people in the Black community, and I can even speak from my own experience, have been in this survival mode, and survival mode because of the traumas we have or haven't experienced, or the traumas that we have to navigate of someone else that's a part of our experience. And so we never really have had an opportunity to, we're never thinking of, okay, let's come together with all our resources. What can we do? You mentioned Fanta, to fight for our lives, but we have our lives, we matter, we are here, and it's, to have to be in that fight mode is exhausting. And I think one of the things that we have to start thinking about is, what can we do to take that energy and transform it into energy and policy and work and different processes that demand that our lives matter. We're here, out here, and live and living color. This is how we're operating, and there's no way for anything else to penetrate what we've developed. That takes time.
Yeah.
But I think what lays the groundwork and foundation for that to happen is what's happening in the world right now, which is very challenging, but a lot of things are being shaped up, which means new foundation can be built and fill in the cracks. So that we're not in that survival mode anymore.
Mm-hmm. And then James, anything you want to add to that in our call to action for justice?
I love all of that. In 1966, Dr. Martin Luther King said, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And I think it's important for us to remember and recall that social justice, healthcare is a social justice issue. We're trying to demand that delivery of high quality care be provided to all individuals. So when we talk about health, we have to understand that we want the same thing that everybody else has already. Like we want to be treated on the same level as everyone else. And so when we're talking about the energy behind the Black Lives Matter movement, I think this is just another pillar that we adopt, that we this social justice lens that says, hey, we want justice in transportation. Hey, we want justice in healthcare. Hey, we want justice in food access. It's really the overarching theme for all the things that we're trying to accomplish. We want a fair shake at what everyone else has so easily.
Now, going back to COVID, I know that's like top of mind for all of us, but we see that COVID is a global pandemic. We're seeing that certain countries are handling the spread and containment much better than the US. Which is a surprise to many, because we're supposedly the greatest country of the world. But then I think that right now, this moment, we're just seeing that that's not particularly true. So let's talk about healthcare overall globally. Are there any countries that you think are doing healthcare right? Can you point to some examples for us? And then can we use those nations as a guide to better our healthcare system? And then James, I'll start with you there.
Okay, I can kick it off. So New Zealand, right, is like the shining star when it comes to COVID-19 response. You have a country with a population of 5 million people. Mm. They have 24 active cases right now, literally 24 cases. And I think part of that is the relationship between government and healthcare. I also think there's this underlying theme of when people understand that healthcare is a right and not a privilege, mm-hmm. that their country went into a lockdown immediately. Mm-hmm. So like COVID-19 is here, we shutting everything down. We're cutting out the mitigation process. We're not going to try to do any risk analysis. We're going straight into elimination of this threat. They went 102 days without a community transmission. I think last week was the first one in that entire span. So you look at other countries who understood we're putting the people before the economy. Mm-hmm. In many cases, it's the capitalist ways that we live in that says, hey, we need to open the economy back up. The economy is suffering. Well, yes, the people are suffering too. The people are dying. Mm-hmm. You can build new goods, new products and services. You're not going to just have another person. And so when I talk about trying to better our healthcare system, I think it first begins with understanding that healthcare is a right, that you need to put people first. And when it comes to response, sometimes you have to take that more stringent approach that says, hey, I'm sorry that we're going to take away your fund for a couple of weeks, but I'm trying to keep you alive for a couple of years longer.
Adrianna, any examples of what you've seen done globally, and like maybe not even within COVID, but also just like healthcare in general that you think, you know, are like great, of course, maybe not perfect, but great examples of how they're, you know, doing healthcare?
Yeah, I would even just say Iceland with this response. Their rates aren't as remarkable as New Zealand, but as soon as this went into action, they also were very aggressive with free testing for everyone that was there, an aggressive contact tracing program, required isolation for all their COVID patients. It's just that aggressive response was not seen as aggressively in other places, and it's definitely shown in the rates as well.
Yeah, and then one thing I wanna kind of hear more about is where you both are located. Just because I feel like the way that COVID has been handled throughout the United States of America has been different within each state. Like every single state is doing their own thing. Obviously, it just shows a lot about politics here. But just like curious to know like where you both are right now and just how COVID looks like where you are. I'm based in New York. I don't think I even have to say, but COVID has been a mess. Luckily, I think that, you know, our governor did do for most part like a pretty good job of like helping us to attempt to contain it. But just curious to know, like from where you both live, you know, what does COVID look like now compared to what it looked like when it first started? And Adrianna, if you want to start.
Sure. So I'm in Massachusetts. And so Massachusetts, I think, has about the lowest rates, some of the lowest rates in the country. We have, however, been raising a little bit. And I think that has just been with warmer weather and people going out and not physically distancing enough. But overall, I think our state in general had an aggressive response compared to the rest of the country. I would say the disproportionate impacts are seen here, though, just as they are in the U.S. The last data I had seen is 40% of the population that was Black is a confirmed case of COVID-19, and that only makes up, 25% of Black people in Massachusetts, but 40% of the cases are Black people, which is immensely disproportionate. And so a lot of work is being done around that, but luckily we've been able to stay lower than the rest of the curve of the United States here in Boston.
What does it look like?
And so I'm in Michigan, and when COVID first appeared, we were one of those states that were on the higher side of the rankings. I think we were actually in the top 10. I think now we're in maybe the top 20 of states. And we have that same stair step of inequity that you see in other places where as a state total, we're 14% Black. And I think there's less than 10 million people in our state. About a third of the cases of COVID being African-American. And then you see 41% of the deaths are African-American. So, you know, make that make sense. How is it that you have the minority of the population making up the majority of the cases and the deaths? I think Michigan did a really good job understanding and trusting the public health data. It was a matter of what am I supposed to do that's going to protect the people, and we moved into a lockdown relatively quickly.
So before we end, or as we end, I just wanted to move into more like action-oriented, practical solutions that, you know, we can end with. So first, you know, what are, just taking this all in over the past 30 minutes, just like talking about these health inequities and like talking about COVID, what are some practical solutions to addressing systemic health inequities? And then also, you know, what are some short and longer term, maybe policy changes that are needed to advance equity and then also to improve some of the health outcomes that we spoke about?
Yeah, some of the things that are coming to mind for me is being informed. And sometimes this space isn't made for us to be educated and informed, but knowledge is power. And
Mhm.
so for one, it is being informed. I think there's a lot of momentum behind action, which I'm here for, but that action has to be informed. It has to be effective, efficient. And I love the momentum around the action. So one that I would just call for is for it to be informed. And from a policy perspective or just accessibility wise, and this is more from the research perspective, I'd love to see more research being done or being led by organizations in the actual communities that are trying to learn more about. Working at an institution where that's not necessarily the case, I see how structurally that may have happened or come about. And I think being able to offer those opportunities and have researchers that look like the community that's doing that work would be really effective. And it takes time and work to get there, but it takes effective and intentional action and plans to make it happen. So those are some concrete things that I would suggest.
And James?
I've got a running list, and I want to echo the idea that when we're talking about releasing data, especially race data, Black communities and Black researchers need to be in that, like understanding the nuance of community, why things look the way they do. I also want to hold up this idea that we need to hold up a mirror to our institutions. So understanding the gaps when it comes to representation. You can do a scan of hospitals across the nation. I think less than 9%, their executive suite, so like their chief executive officer, and those folks are Black. When you have less than 10% making decisions for like huge regions of care, those voices are left out of the room. So I would love for institutions to say, well, why isn't there anybody Black on our board? Why isn't there anyone Black in this room helping to make decisions? And just a few, I'm going to call these easier things. We need to increase equitable healthcare coverage. And that's not to say that Medicare for all is the answer, but everybody needs a base care coverage. You see that right now, especially in the middle of a pandemic, people are being laid off left and right. What was the safety net?
Right.
Making sure that people have access to that, because you can look at the inequities in that as well. There's significant gaps, even through Affordable Care Act, for African-American families when it comes to healthcare coverage. So if I have to say anything, it's Black folks need to be at the table when it comes to releasing that data. Institutions need to take a strong look in the mirror and say, why are we not getting this right? And 3, make sure that people have the safety net when it comes to healthcare coverage.
Absolutely. And that's great. And just to kind of end, what is a call to action that you have for our audience today? Because I think that a lot of times when we may not sit in these respective sectors or really fully understand it or really think that we can, take action to, make policy changes or whatever it may be. Are there things that our audience members can do today, do tomorrow, that they can do to kind of help us get to a place where we live in a more equitable world, and especially in terms of healthcare?
I would say look at some of your local legislation. I think one of the things that I wasn't as cognizant of is what was being put forth to be voted on and what legislation aligned with what I was passionate about and wanted to create change with. And you can just call up your local offices and speak to your representative. That makes a world of change. Tell them who you are, tell them what your ideas are, tell them where they can find you and people that look like you. You can do that today, or well, it's Saturday, but you can do it when the offices are open. You can do that at the start of the week, and it makes a difference. One phone call, they can remember, hey, one day this person called me and they told me something that I had no, let's change this bill. So you can do that.
James, any final words?
I love to assess my own power and privilege, right? Just knowing that I have influence in certain spaces. So being able to advocate in my respective space, looking at policies in my own organization and how they disproportionately impact people of color. So I come from a public health background. I love the idea of health in all policies. Let's flip that on its head and talk about Black in all policies. Make sure that Black folks have access to the things they need, that you're taking into consideration what the Black experience is in policymaking across sectors, because we want to improve health for all our communities and our people. I mean, that comes down to the design of our communities, where our grocery stores are, where our hospitals are. Like, I want to make sure that people have access to the things they need when they need it. We shouldn't have to wait for a crisis to occur for us to say, oh, we need to tear down the system. No, we've known this for 400 plus years. Let's tear it down and build it the right way.
Mm-hmm. That was a great way to end this. So we're at time. This was great. Thank you both for joining me on a very, very important discussion, not only for today, but just really important for our community. So thank you so much for joining me. Thank you everyone for attending. We have plenty of other sessions taking place throughout the day, so please feel free to join some of them, and you'll definitely see the intersection, you know, with healthcare, I think, in some of those sessions as well. So please attend those. If you want to reach out to us, we should have our info, I think, on the Instagram page, so definitely look there. But thank you all for attending, and thank you, Adrianna and James, for doing this with me.
Thanks for having us.
Thank you. Bye.
Bye.